Welcome everyone to the last webinar of this year. Today we'll have again 4 interdisciplinary case presentations, and it is my great pleasure to welcome today Wunder from Toronto, Philipp Funovics from Vienna, and both Veronika Blum and Beata Bode from Switzerland. During each presentation there will be questions to the audience, and please feel also free to submit your own questions as usual. I'm very happy to welcome today again Axel Luzern from Paris, and as well as our panel, which is complemented next to the presenters, of course, also by Gunhild Mettersheimer and Frank Traub from Germany, and as well as Joanna Scandera and Bernadette Diegel-Atzelwanger from Austria. The webinar will, as already mentioned, be recorded, and you can access it under the respective website. Last but not least, I would like to thank to our sponsor Pharma, Bayer, Novartis and Implancast to support this webinar. Now it is my great pleasure to welcome Beata Bode to start with her first presentation.
Okay, so thank you all for the invitation to be the first pathologist actually talking in this round. It's a great pleasure, and as a pathologist, I would, as the first pathologist, I would like to kind of compensate my first presence here by presenting a generic patients represented by 4 different patients. So all patients we will be talking about in the next 10 minutes are adults with deep myxoid tumors, and I would like to discuss with you some diagnostic aspects of histopathologic diagnosis in such cases. So the patients are all adults. They have a history of some weeks of a palpable mass on the thigh or buttocks. They all have no further disease manifestations, and they have no relevant medical history. If you look at the imaging of these 3 patients, the lesions look more or less the same. They are sharply demarcated, and they show myxoid imaging aspects. They are, well, very similar on imaging. So the question is, of course, are those the same tumors or not? And then, of course, as in all such cases, we proceed with a core biopsy. Here you can see the core biopsy of all 4 patients, and as you can see, they are all rather paucicellular, and they are all composed of some mixture of really quite bland-looking cells with more or less prominent vascular pattern. So my question now for you, how many different entities are these 4 patients? Is this all the same? Are those 2 different entities, 3, 4, all different?
So we have now the result. 1 is 29%, 2 is 7%, 3 is 14%, and all different 4 is 50%.
So all different is the favorite, with some having the 1 option.
Yep.
Okay, so let's go through our pathological kind of process of arriving in the diagnosis in order to be able to give the patient the correct treatment. Of course, we want to arrive at the diagnosis of one of the entities included in the current classification of the soft tissue and bone tumors from 2020. And we need for those clinical presentation and histopathology. That's what we already have. We need some immunohistochemical information, and if possible, if needed, we probably will need some molecular genetic information. Why is that? If you consider the differential diagnosis of myxoid mesenchymal tumor, you have a large list of both benign and malignant entities, which comes in questions. in question, of course, in this location, while nodular fasciitis will be less plausible, or the dermatofibrosarcoma protuberans, but there are still enough entities left to make a differential diagnosis not that easy. In this context of mesenchymal deeply located tumor, there are some very important antibodies which are kind of basics for this differential diagnosis. Of course, neural differentiation like for schwannoma or neurofibroma, S100, SOX10. Then there is this very important antibody MUC4, which would let us include or exclude the differential diagnosis of low-grade fibromyxoid sarcoma. Then very important, quite common CD34 antibody, which has a very special meaning for us pathologists, soft tissue pathologists, because it's ruling out several entities like synovial sarcoma. And this may be positive in many other entities. And then there is, of course, some additional antibodies and proliferation index, which help us diagnose the tumor, but will not let us arrive at the final diagnosis in most cases. So if we look at immunoprofiling with this basics antibody, we can see all MUC4 were negative. There was some CD34 positivity in the first tumor, while the other ones were negative, and S100 was partially expressed in the two last cases. So based on this immunoprofile, it is possible to, combined with the histopathology, it is possible to kind of diagnose the first tumor as an intramuscular myxoma. However, the differential diagnosis is still open for the three other tumors. So we proceed with molecular testing. As you know, many of the soft tissue tumors, including myxoid soft tissue tumors, are characterized or defined by genetic aberrations like translocation, amplifications, point mutations, deletions. Actually, there is also genetic aberration in an intramuscular myxoma genus point mutation, but you do not really need for diagnostic reasons perform this, in most cases, perform this study to arrive at a diagnosis. Most cases, it's enough to have this immunoprofile and a fitting presentation and histopathology. So how do we detect these genetic aberrations? We have several tools to do it. At the molecular level, we have fluorescence in situ hybridization, PCR, NGS, and all those methods have the advantages and disadvantages. FIS is quick, PCR is quick, NGS is very comprehensive, but it lasts longer. You can, with next generation sequencing, you can study multiple genes, and as you can see here in this picture at the same time. However, you need definitely more time as for FISH and PCR. So the first approach will be FISH and PCR. Since you definitely will have as a pathologist the differential diagnosis for your tumors. So if you consider the differential diagnosis, which is most important in this context of myxoid liposarcoma, you would go for testing either with PCR or with FISH. And as you can see here, the second tumor is actually negative for all gene rearrangements which occur in the myxoid liposarcoma, while the two lower tumors, tumor 3 and 4, seem to contain the DDTI3 translocation, one accompanied with the translocation of Rus gene, the other one with the translocation of the EWSR1 gene. So let's say these two tumors we kind of solved. So these two are myxoid liposarcomas with two different translocation, and in the fourth tumor, and not only the translocation was found, but also some more cellular areas next to these pictures, which let diagnose the tumor as containing round cell component. So unsolved question remains after the second diagnostic round in this case number 2, where we have non-specific immunoprofile and nothing helpful in the fish. So we proceed with we proceed with NGS, which takes a week or a little bit longer. And in this study, we detected the gene fusion AHRR NCO02. So this tumor number 2 corresponds to a benign angiofibroma. Sorry, I should say angiofibroma of soft tissue. So in fact, all those tumors, sorry for this misspelling, it's angiofibroma of soft tissue. So at the end, we end up in those 4 patients presenting with a clinically and on imaging quite similar tumors with 3 or 4 different entities, depending how you consider these two. 2 are benign and should be kind of taken care of by surgeons, and the other 2 are malignant with different malignancy grades, where local and systemic treatment may be discussed. So actually solving our questions, these are 3 different entities, 2 benign and 1 malignant. Take-home message: myxoid mesenchymal tumors have a broad differential diagnosis of both benign and malignant entities. Pathologic diagnosis is definitely a basis for therapy decisions. We have auxiliary studies to solve the questions. Mostly we will need in this context molecular methods. There is this important time factor. That's why we try always to get as far as possible with simpler methods. But in some cases, we need to wait for the result of more sophisticated methods in order to be able to install the correct diagnosis, the correct therapy. Thank you for your attention. Would be all on my side.
Beata, thank you very much for this very nice illustration of the stepwise approach that you, as pathologists, need to go to diagnose these myxoid mesenchymal tumors. I think in this context, if I would like to pass on the word to Bernadette to comment from your side, from the pathologist side, and then I think we initiate the discussion.
Beata, thank you very much for presenting these excellent cases showing the diagnostic dilemma sometimes for pathologists. I have 2 questions. The first question is, do you do the DDET3 antibody, the fusion-specific antibody, to be sure that you are dealing with a myxoid liposarcoma, or do you test every time with an fish or with next generation sequencing?
Well, I must say I prefer to go for fish, because it's more or less the same time span we need for the study, and in this context I prefer to have the molecular test rather than only immunohistochemistry. It's not well established antibody, and I haven't checked how reliable it is, and at the end, in questionable cases, you have to go for fish anyhow.
And one additional question we get most of the time, these small core needle biopsies, and especially if we are dealing with these myxoid lesions, it's quite difficult. So in the case of a cellular intramuscular myxoma, sometimes you are in a dilemma with a low-grade myxofibrosarcoma because you can have some curvilinear vessels and sometimes also some nuclear atypia. So CD34, is this enough for you to go with cellular myxoma, or would you then do a GNAS mutation?
I must say, so one of the very important additional studies in this context is imaging. Because if you see, like a round tumor within the muscle, it's pretty sure intramuscular myxoma. And my experience with testing, molecular testing of GNAS mutation is difficult because the cellularity is also very, very low, and you need some special testing. I don't know what's your experience, how often it's disappointing to go for the mutation testing.
So I love to test with the GNAS mutation, and with the new NGS panels, even if the cellularity is very low, we get very good results. So in more than 90% of cases, I would say 95% of cases, I get out the GNAS mutation. And then I'm pretty sure, because especially in consult material, if you only have the biopsy and you do not have the imaging, it's tricky, because also in the myxofibrosarcoma, I sometimes have this CD34 staining.
Yeah, definitely. CD34 is definitely not final diagnostic for almost any entity. But I think that the factor of time is in this, the factor of time, and it's still easier to get imaging in my setting than NGS within 2 days. So for questionable, I go also for GNAS testing, but it's not that common.
Any further comments from the others? I mean, I think, Jay, please go ahead.
So, obviously, we see a lot of these patients and, refer them for biopsy. And, it's generally thought that most intramuscular tumors that are homogeneously preyed on T2 are benign myxomas. And then intermuscular tumors, like within fat, between muscles, whether they're homogeneous or heterogeneous, are typically thought to be myxoid liposarcoma. But in your example 3 and 4, example 4 was an intermuscular tumor in the popliteal fossa within the fat. Looks like a really classic myxoid liposarcoma, and it was. But example 3 was intramuscular in the gluteus maximus in the buttock, also homogeneous, yet it turned out to be myxoid liposarcoma. So it just goes to show that, you can say in general, you never say never and you never say always. And so it just goes to show that every myxoid tumor really does need a biopsy, no matter how sure you are of what it is. And even when we see small myxoid tumors in muscle that are asymptomatic or picked up incidentally, and we're pretty sure they're myxomas and want to just send the patients away, we always do a needle biopsy, because there are these unusual intramuscular myxoid liposarcomas which don't fit the rule, so to speak. So I guess that's kind of one of the learning points from the radiology for us, because we sort of see these patients up front.
Yeah,
Awesome.
absolutely agree. And, from my pathology experience, it's better to, do one biopsy more than one not enough, and then you get in trouble.
Okay. May I just have a short question? I hope I didn't miss it, but what was the grading of those 2 myxoid liposarcomas?
So on core biopsies, the first was exclusively myxoid, and the other one had 20% of round cell component.
Okay.
In the core biopsy.
Yeah, I think one of the things in the future for these is, like, this would be a really great AI learning project. Could you use AI with radiology, MR, to actually differentiate a benign versus malignant myxoid tumor? Because if radiology could do that accurately, it would certainly save having to biopsy every single one of these, and then you could just biopsy the ones that weren't clear. But yet to be done.
Just a rapid comment. Thank you, Beata. It was a nice job. This presentation highlights the complexity of mesenchymal lesion in general, from benign to malignant tumor. So we understand the complexity for a radiologist to make a diagnosis only based on radiology. It's impossible. So It is typically the case where biopsy is fundamental to make decision making before any upfront surgery. Between a myxoma and a myxoid liposarcoma, round cell liposarcoma, it's totally different. So, and pathology, microscopic pathology is not enough. So, and we have time to make this biopsy because the low grade evolution, KI 6, 7, 3%, 10%, 0%. So we have time to make a biopsy and this biological test before any upfront surgery.
Well, as
Great.
a pathology, you actually have a more or less idea, you know, looking at H&E, but you need to kind of present as with some objective methods. And you know, it's statistics and individual case. So this is, you know, even if most, like 99% of cases is something, and you have, you know, bad luck with 1%. So it's better to go for sure.
Well, for the sake of time, we really need to move on. Thank you so much, Beata. Illuminating. Philipp, do you want to proceed?
So I would like to come up with a rather basic surgical problem, but that is a problem that really seems to be unresolved in current literature, and that is the reconstruction technique after intercalary tumor resection of the femur. So we are all aware that the femur is a very common site for tumor, and most of the primary tumors occur in the metaphysis or close to the epiphysis, and this very frequently requires articular resection. And then today the gold standard is regarded to be modular prosthetic reconstruction. However, in intercalary reconstructions, or in diaphyseal tumors, we might get away with intercalary reconstructions, still providing wide resection. These reconstructions, as they preserve the joints, may provide superior function, but the challenge is the limited bone stock for anchorage of whatever we use as a mode of reconstruction. There are several modes of reconstruction in these patients. Allografts have been described, vascularized fibular autografts, a combination of allograft and vascularized fibular or extracorporeal devitalized autografts, maybe also together with vascularized fibular distraction osteogenesis, and of course segmental intercalary endoprosthesis. So the aim of this presentation that actually comes up from one of our M&M conferences was to discuss different reconstruction techniques, namely intercalary endoprosthesis and biological reconstruction for intercalary segmental femoral defects and discuss their morbidity. So here I come up with two cases, or the first one being a male patient, 28 years, with a diaphyseal osteosarcoma, epithelioid subtype G3 upon histology. He was first diagnosed with that tumor in 2017, underwent neoadjuvant chemotherapy according to the Uramos protocol, but we noticed tumor progression under chemotherapy that was regarded to require earlier surgery than planned. And case 2 is a male patient, a little bit older. He had a diaphyseal osteoblastoma, which was firstly diagnosed in 2014. He underwent tumor curettage and cementation, but developed an extensive recurrent osteoblastoma. So here are the two cases. On your left-hand side, you see the lytic defect of the diaphyseal osteosarcoma in this femur with a large cortical defect, and here the vast expansion of the osteoblastoma in the diaphyseal shaft of the femur. Here are the correlating MRI images. This is the vast tissue expansion, which got bigger and bigger under neoadjuvant chemotherapy of the epithelioid sarcoma. And here you see the cortically situated osteoblastoma. Centrally, you see the cement, the residual bone cement from cementation, and here a big, huge recurrence around. So my question now out to you is, how would the surgeons amongst you reconstruct the defect after its wide resection? 1, massive allograft or devitalized autograft. 2, a vascularized fibular autograft. 3, a combination of either allograft or autograft together with a vascularized fibula. 4, an intercalary endoprosthesis, or you say, no, all of this is too risky for me, I go with a total femur endoprosthesis.
So we have now the answers. For the first option, massive allograft or devitalized autograft, 7%. For the fibular autograft, 13%. For the combination of both, 33%. For the intercalary endoprothesis, 40%. And for the total femur endoprothesis, 7%.
Okay, so we have a majority for intercalary endoprosthesis, followed by the combination of a vascularized fibular. And that is that makes me very happy, because that is actually the two options that we chose in these patients. Case A was indicated to undergo intercalary endoprosthesis, as we had to bring up the surgery earlier than expected, so there was no time to order or to find a massive allograft in that short period of time. And case B underwent the biological reconstruction using a massive allograft and a vascularized fibula. So for case A, we decided to use the Zimmer Biomet OSS system, as it comes along with the compress fixation. Surgery time in that case was 4 hours, whereas in the other patient, we used an during surgery, we used a temporary external fixator to stabilize the defect, and then put in the vascularized fibula with a massive allograft and plating. And as you can see, the vascularized fibula, of course, takes a longer period of time. Here are some of the intraoperative pictures. Here's the huge osteosarcoma with intercalary resection. Here you see the temporary external fixator to stabilize the defect, the osteoblastoma taken out. Here are the resected specimens, both revealed wide resections. For patient A, we used the compress system, which allows to have shorter extension of bone stock for the anchorage of the prosthesis, as you fixate the spindle, and then with the compression system, this base plate is screwed onto the bone, and this compression, this is hydroxyapatite coated base plate, and throughout this compression, the bone should grow onto the plate, giving further rotational stability to the device. And here is the hot dog technique, as described by several authors like Cabana and Hazem-Özker, where we take out the segmental defect in the femur, take out the vascularized fibula, wrap a massive allograft like this one around the fibula, as you would have the hot dog with the warm sausage in the center and the bread wrapped around it. This is the devitalized bone that can be an autograft or an allograft or an irradiated autograft, and is then replanted to be fixated with a plate. So here are other intraoperative pictures. Here, the preparation of the compress spindle, whereas here you see the plate and the allograft in situ. Here are the stems and the cones for fixation of the intercalary prosthesis. Here is the allograft that is then flipped around the vascularized fibula, and this is the final result with the intercalary endoprosthesis and the intercalary defect reconstructed biologically. So here are the intraoperative or post-surgical X-rays with the intercalary prosthesis fixated with 2 spindles in the upper and lower bone. And here is the centrally located fibula with the allograft around it and plate, and then the fixation of the residual fibular ends to give better stability for the joints. So in our aftercare, we had the patient with intercalary endoprosthesis non-weight bearing for 6 weeks, partial weight bearing for another 6 weeks, whereas the biological reconstruction underwent non-weight bearing for 12 weeks, and then the use of a customized orthosis with limited knee flexion in the beginning, but still wearing the orthosis for at least 4 months. So much longer rehab time for the biological reconstructions. Here are follow-up x-rays of these patients, and I would not present those if everything went fine. So the patient with intercalary endoprosthesis ended up with a fall and a huge trauma to his knee joint 17 months after operation, and had a distal loosening, which had to go undergo revision surgery, whereas the biological reconstruction developed a pseudoarthrosis in the proximal junction and underwent 3 times an extracorporeal shockwave therapy, with the last one being applied 17 months after surgery. Here is the pseudoarthrosis to the proximal junction. And when you're very critical, you would clearly say that upon last follow-up, which is a year ago, the patient still has not fully consolidated, but you can see osseous junction in the ventral part of the bone. He's doing fine, walking without crutches, no pain, and good function of his joints. And here is case A. After fall, he presented with this bending of the spindle, and the base plate getting ripped off the bone. So we had to revise. And my question now is, how would you deal with that kind of complication? Would you redo the compress system, as the upper compress system was kept in situ? Would you do a short cemented stem, maybe with extracortical plates? Would you do distal femur prosthesis? Would you say, no, I have enough of this compress system, I'm switching to the total femur prosthesis? Or would you say, now, since the patient is fully out of chemo, I would now switch to biological reconstruction in this young patient?
Yes. Oh, it's for the redo compress is 27. For the short cemented stem, it's 20%. For the distal femur prosthesis, it's 27. For the total femur prosthesis, it's 7%, and switch to biological is 20.
Very interesting. So the majority of you would have switched to either redo the compress or distal femur, which was equally distributed. We didn't dare to actually redo the compress system, so we switched to a short cemented stem. Unfortunately, in that system, it does not provide extracortical plates. So probably happened what had to happen, and the stem had aseptic loosening. The patient was repeatedly diagnosed to have no signs of infection with multiple negative aspirations. So it was aseptic loosening with the stem and the cement mantle protruding into the knee joint and correlating pain. So he then ended up in a distal femoral reconstruction with the proximal compress system still in situ. He's doing fine, ambulating normally, and no signs of recurrence. And you can see that also the proximal compress has healed in with this elephant foot sign onto the base plate. So in terms of discussion, we see the pros of endoprosthetic in modularity, easy handling, and quick surgical time. Patients are quick out of bed, and these systems, due to the possibility of cementation, may perfectly go along with adjuvant therapies and limited modes of bone healing. However, we do see loosening mainly due to rotational forces, and especially the femur was reported to correlate with a high complication rate in these patients, and these patients bear the lifelong risk of infection. Whereas biological reconstructions, as the name suggests, are biological, so once they are healed in, they seem to be very resistant to failure and long-term complications such as infections. However, in the early phase, there is a high rate of fracture, and especially also implant fraction, plate fraction in patients with long-term non-unions. It is a complex and very time-consuming surgery, especially when applied together with vascularized fibula, and these patients have long rehab. So this maybe is more restricted to a younger age group with a long life expectancy. But there is a very recent good read, which is a literature review by Erani, published this year. You see that non-union and aseptic loosening rates in more than 20 papers are rather equally distributed between all the different modes. Implant failure, fracture rates, there simply is no answer to what the best mode of reconstruction for this patient is, and also MSDS score representing patient function is rather identical amongst all these different procedures. So in conclusion, we believe that intercalary endoprosthesis allow quick weight bearing, probably more for elderly and palliative patients. Once integrated, biological reconstructions permit full weight bearing and have perhaps fewer long-term complications. There's still controversy whether or not these allografts or devitalized autografts should be associated with vascularized fibula, because it's the longest surgical time, there's donor site morbidity, but these fibulae could improve the union rate and rescue mechanical failure. So, and to conclude my presentation, I would be very interested in whether or not any of this has changed your attitude to your primary indication. I would like to come back to my first question and see whether that has whether you would alter your treatment options now.
So now we have 50% for the combination of option 1 and 2, 33% for intercalary endoprosthesis, 8% either for the total femur endoprosthesis or the massive allograft or devitalized autograft, and no percent for fibular autograft.
Okay, very interestingly, option 3 obviously has won this race, which clearly is an unanswered problem to the best option of surgical reconstruction. Thank you very much.
Philipp, these are two great cases. Really have to be commended. Thanks so much. In this moment, I want to pass on to Frank and Jay. I mean, how do you want to comment?
Sure. So can I make one comment and then question? Yeah, I mean, first of all, I think it's great cases, and those are great X-rays and great outcomes. We would, a lot of these patients with reticulary defects, we would do just an allograft reconstruction. We tend to use allograft with fibula in younger kids maybe, but in most adults, we just use an allograft. And we do it a little bit differently because we cement the canal of the allograft, and we usually use double plating if it's in the lower extremity. And one of our fellows from a couple of years ago did a paper in BJJ, so it was 50 cases, and there was only 6% non-union and very few infections, and about 88% of the grafts were salvaged. So for most adults, we would actually just do that, and the results are pretty good. I mean, I think in young kids who are very active, obviously adding a fibula is a really nice way, but the cement and if you put cement in the middle, you add antibiotics, you do 2 plates. The results, at least in this series, were really good. It was a pretty standardized thing. Like Frank's probably did that a lot with us. So my one question, though, was for the young kid. I was a bit surprised that you didn't actually do a biologic reconstruction, right, because he was 28. So I just wonder, was the choice of a prosthesis because he grew on chemo, and generally if you grow on chemo and Ewing's, you probably have bad necrosis, and that correlates with a bad outcome, and you figured you should just do the simplest thing to get him up walking because his prognosis is pretty poor? Was that sort of the thought?
Exactly, that was exact, because I do agree we would probably also rather tend to do a biological reconstructions on intercalary defects. But in that case, the tumor was rapidly growing under chemo. It got bigger and bigger with every week. So we had to interrupt the neoadjuvant chemocycle and get him on the table. So that was just and we didn't expect him to be a responder. And in fact, he was a fully vital resected specimen. So he was no chemo responder at all. Fortunately enough, the patient now is 3 years out of surgery, and he's free of any recurrence. So yeah.
He's a great example of how process in osteosarcoma and Ewing's is our best predictor of outcome for localized disease, and yet it's not a very accurate predictor for any individual patient.
Exactly. Yeah.
I mean, that's probably why the new protocols don't actually change chemo anymore after bad response, because it doesn't mean you're going to have a bad outcome. It's quite a very challenging problem.
Nice talk. I have actually two questions. The first is, why didn't you change to a biological reconstruction after the failure of the first procedure? And the second one, do you have any clue, hint, or knowledge about how long the vascularized fibula is actually vascularized? Do you have any idea if it's still vascularized after 2 weeks, 3 months, or do you know if there's any data on this topic? Because we use quite a lot of devascularized fibula and have even similar results with the union. So the question is, do we actually need always a vascularized fibula?
No, you're absolutely right. And we did a paper some years ago published in BJJ where we looked into exactly that and tried to investigate whether there's any difference between vascularized and devascularized fibular strut grafts. And we were basically unable to identify a basic difference in those. But there is evidence that actually the vascularized fibulas stay vascularized over a very long period of time. From Bologna, Manfrini has published a paper where he was able to show that in long-term survivors out of surgery who eventually die of metastatic disease 6, 7, 8 years after surgery, he was able to show that these vascularized fibula in the center of the allografts really develop hypertrophy and then revitalize the allograft. So I think, I think in kids it is really a big advantage. But I think Jay is right. For adult patients, you're probably better off to put cement in the center of the allograft and certainly double plate the patient. I agree with that.
Yeah, two questions from the audience. They are, let's say, technically related. One goes, how do you monitor the vascularized fibula? Do you use an island, and how do you hook it up? And another question aims at the length of the fibula with respect to the osteotomy side. How much do you overlap? Do you have any rules there?
So the first one is a very good question, because I was always discussing that with the plastic surgeon during the hour we take extra to do the microanastomosis. We have a lot of time to discuss that. And in fact, there is no real tool to probably monitor the vascularization stages of the fibula. It would be interesting to look in maybe bone scintigraphy and to see whether that would be helpful to get any information out of these vascularized grafts. But in fact, it is an information we don't look into because it I think would not really have a clinical impact. We would never revise a patient if we saw that the fibula was not vascularized after surgery. So we are not really looking into that for clinical purposes. And the second one is, we try to overlap the fibula with the host bone. And in the femur, it is frequently very, very comfortable to just put the fibular strut into the bone, and I usually take 1.5 or 2 centimeters of overlapping. But that is just a rule of thumb, no scientific evidence.
Philipp, thanks so much. Just awesome. I think
For the femur, you're often just limited how much you can overlap it by how long their fibula is and how long the defect is. And we've got lots of times where you can have a centimeter if you're lucky, and a lot of long resections
Exactly.
barely overlap it, and that's a problem. And then sometimes you can only overlap one end and not both ends. So there's a
You
limit.
have to always make sure that you keep 6-7 centimeters of the distal fibula to not provoke joint instability to the ankle. You can go higher up in the proximal fibula.
If you leave a small fibula segment, do you always put a screw across the syndesmosis, and do you leave it intact, or do you take it out at some point?
Proximally, yes. That was not my personal case, the one here. Distally, I leave 6 centimeters, and the study actually comes out of Graz by Laura Ertl, where he looked into what segment of distal fibula do we actually need to keep the ankle stable, and he came up with 6 to 8 centimeters.
Thanks.
well, thanks so much. We have to move on. Veronika, we don't see you, but can you share your
Yes,
presentation
I'm
with us?
sorry that you cannot see me. I hope you can hear me well. I'm happy to present you a patient of mine who was treated for a metastatic mesenchymal chondrosarcoma with Cabozantinib. The patient first presented in September 2019 with a swelling and pain in the right lower leg. And on the radiograph made by the family doctor, you can see this lesion here. The family doctor also performed an MRI where you can see this tumor here. And due to this, the patient was sent to our sarcoma unit. A CT scan of the lungs was done and there were no metastases found. A biopsy was done, but it was not conclusive, so it had to be repeated. And in the second biopsy, there was the diagnosis of a mesenchymal chondrosarcoma with the diagnostic gene fusion in HEY1 and COA2 made. Mesenchymal chondrosarcoma is a rare sarcoma subtype accounting for 2 to 3% of all chondrosarcomas. These are aggressive tumors with a 5-year overall survival of only 37%. And the treatment recommendations for mesenchymal chondrosarcoma are inconsistent. The NCCN recommends following the Ewing sarcoma protocols and regimens. The European Society of Medical Oncology state that localized mesenchymal chondrosarcomas are usually treated with adjuvant or neoadjuvant chemotherapy combining anthracyclines and alkylating agents. So the first question is, how would proceed? Would you go for surgery straightforward? Would you go for preoperative or neoadjuvant chemotherapy followed by surgery? Or would you go for preoperative radiotherapy followed by surgery? Or would you combine these two modalities and then do surgery? Or would you watch and wait due to the benign behavior of chondrosarcomas?
So we have answer 1, surgery 13%. We have 56% for preoperative neoadjuvant chemotherapy followed by surgery. We have preoperative radiotherapy followed by surgery with 6%. And we have 25 for preoperative chemotherapy and radiotherapy followed by surgery, and nothing for option watch and wait.
Okay. So we decided to go for surgery. On the left-hand side, you see a 3D reconstruction of the tumor and the planned osteotomies on the tibia. The patient got patient-specific instrumentation for these osteotomies. You can see the planning of these in the second image and the planning for the allograft on the third, and the reconstruction with the plate fixation on the right side. This is the intraoperative exposure of the tibial tumor, and you can see in comparison the 3D printout of the to be resected specimen. On the left side, you can see that this patient-specific instrumentation was fixed on the bone, then distracted, and on the right lower side you see the patient after the mobilization of the tumor. The osteotomies were verified with the 3D printout, and on the right lower side you can see the probing of the plate in the patient with the allograft printed out. Here you can see how the allograft was prepared, and also the osteotomies on the allograft verified. And then there was also taken a vascularized fibula, and the patency of the vessels was proven, and then there was put all together as we have seen before in this hot dog technique, as I learned today, because I'm not surgeon and I have not lots ideas about all the operative techniques. And this is the finished operation with the plate fixation in the patient. These are the postoperative images, which all showed a good result. And the histology of the resected specimen was again a mesenchymal chondrosarcoma. It was resected R0. Then the patient was proposed to go for adjuvant chemotherapy with vincristine, ifosfamide, doxorubicin, and etoposide over 6 cycles, but the chemo was rejected by the patient. The patient had lots of concerns due to the beginning of the COVID pandemic. In general, she is very skeptic towards oncologists, especially, but also to conventional medicine, and she received support from an alternative doctor. And also the latency since the diagnosis was made was quite long, so the patient argued that until now she has no other tumors found, and she was convinced that there will no others be found in future. In August 2020, there was a fracture of the osteosynthesis material, and a revision operation had to be done. There was another fracture, unfortunately, in May 2021, and finally there was an intramedullary nail osteosynthesis done. Shortly before this, the patient presented with pain in the lower back, and the MRI showed multiple metastases in the lower spine. The PET-CT scan showed also metastases in the ribs, in the pelvis, and also in the femur on both sides. Because of the concerns about stability in the lumbar spine, and osteosynthesis of the lumbar spine was done, and also due to concerns of the stability of the right femoral neck, there was a prophylactic osteosynthesis done. After these operations, patient received radiotherapy of the lumbar spine, the left hip, but also of the right ilium, where a big metastasis was, and the right hip. And after this radiotherapy, another PET-CT scan was done. Here, the irradiated lesions showed significant less FDG activity and responded well to radiation, but there were a lot of new metastases in the skull cap, in the spine, in the ribs, in the homily on both sides, and also in the femur on both sides. There was no new risk for fracture or instability, and the question now is, how would you proceed again? Would you watch and wait due to the benign behavior of chondrosarcomas? Would you go for surgery and or radiotherapy of as much lesions as possible? Would you go for a single agent chemotherapy or a multi-agent chemotherapy or a treatment with a tyrosine kinase inhibitor?
We have 64% for multi-agent chemotherapy. We have 21% for tyrosine kinase inhibitor. We have 7% either for watch and wait or for single agent chemotherapy, and no one selected surgery and or radiotherapy.
Okay. that most were for multi-agent chemotherapy. So that's what we proposed. The patient, the palliative multi-agent chemotherapy, doxorubicin based, but the patient refused the chemo again due to the same concern she had before. And you for sure all know this paper about Cabozantinib in patients with advanced Ewing and osteosarcomas. So we proposed this to the patient because there was in 26% of Ewing sarcomas and 12% of osteosarcomas a stabilization or a partial remission of the disease. And patients had a lot of patients had previous lines of treatment in this study, and we proposed this to the patient because it's the only because this medication was done in an osseous lesion, and the patient accepted to get some therapy like a tyrosine kinase inhibitor, which is not chemotherapy. Then the patient started on treatment in the 21st of June, first with 60 milligrams a day. It had to be stopped due to her hand-foot syndrome. Then 2 weeks after it was restarted with 40 milligrams a day, it had again to be stopped due to recurrence of hand-foot syndrome. And since beginning of October, patients is taking 20 milligrams a day without side effects now. And the first 2 weeks of therapy, patient had markedly increased pain, especially in the ribs, in the arms, but also in the back. And 4 weeks after the start of therapy, the pain clearly improved. The dose of painkillers, including opiates, could be reduced. And apart from hand-foot syndrome, there were no side effects under the therapy until now. And we did another PET-CT scan in the beginning of October. Then patient only had 6 weeks of therapy, and PET-CT showed a partial metabolic regression of the bone metastasis, and no new metastases were found. So, what the question is, what is the mode of action of Cabozantinib? In a paper written from Wang and his colleagues, they proposed that the HEI1 and COA2 fusion protein may recruit co-activators of some Notch and HEI target genes instead of recruiting co-repressors. They also described in the paper how this fusion leads to a mesenchymal chondrosarcoma. But absolutely we don't know how it works. We know that there is a crosstalk between MET and Notch pathway, also described in renal cell carcinoma. So maybe this could be an explanation why it helped. But Cabozantinib also inhibits a lot of other receptor tyrosine kinases, such as VEGFR and a lot of others. So we don't know, and maybe it's also due to the inhibition of VEGFR. There are some papers about the treatment with Cabozantinib in sarcomas. The paper mentioned for Ewing and osteosarcomas, but there are also data that it is helpful for uterine carcinosarcomas, for clear cell sarcomas, for alveolar soft part sarcomas, GIST, and undifferentiated pleomorphic sarcomas. There are a lot of trials ongoing using Cabozantinib for treatment of sarcomas. At least 10 are ongoing and results are awaited. My take-home message is that Cabozantinib has been shown to be effective in a patient with mesenchymal chondrosarcoma. Depending on the duration of the response of the patient, additional patients with mesenchymal chondrosarcoma should be treated with Cabozantinib to determine whether the effect is reproducible, and it remains unclear why Cabozantinib has an effect. Characterization of downstream targets of the HEI and COA2 fusion proteins would be needed to identify the mechanism of action and also novel therapeutic strategies.
Veronika, thank you very much. Great case. And I think we need to spend some words on that. Maybe Joanna and Axel, I don't see you, but please comment from your side.
So as it is it's a subtype that is chemotherapy sensitive. We would go in our center for a chemotherapy according to sarcomas. So I firstly would have started with anthracyclines and combined with ifosfamide. That would be my suggestion for this subtype of tumor.
Yeah, me too, more or less the same. It's a nice presentation. The patient refused chemotherapy to highlight the beautiful efficacy of TKIs. I don't know really why sarcoma in general are sensitive to Cabozantinib. I think it's the same thing for Pazopanib and for Regorafenib in this disease. Maybe the anti-VEGFR, maybe more than the translocation fusion. Like Joanna, non-osteosarcoma bone, like mesenchymal chondrosarcoma, leiomyosarcoma of bone, synovial of bone, some patient like that. We start by chemotherapy, sarcoma regimen. So if in neoadjuvant situation, I think the patient not reject in neoadjuvant situation because the tumor is inside. So there may be less refusal when there is a program with induction chemotherapy followed by surgery. After surgery, more complex. We are in adjuvant situation, and of course, I understand that the patient can refuse because they don't know exactly the risk of relapse. But it's an aggressive disease. Mesenchymal high-grade chondrosarcoma of bone is an aggressive disease, like an osteosarcoma. So we have, theoretically, to treat this kind of patient like osteosarcoma. So the patient, after that, in case of relapse, can receive in second line TKIs. And TKIs are active, not so inactive. But I don't know what is the mechanism of action of Cabozantinib.
I completely agree with Axel. Yes, we also would go now as the paradigm is changing to more neoadjuvant therapies. Then we would go for neoadjuvant treatment, and then you can also see if it's working or not, the response rate.
Yeah, we tend to use Ewing's chemo for most of these bone mesenchymal chondrosarcomas. I mean, typical of the worldwide discrepancies, and we've seen some really amazing responses with high rates of necrosis and tumor shrinking. But you know, 2 different guidelines, 2 different continents, 2 different databases, so it's a very difficult problem for us. Try to sort these things out.
And what's your suggestion then? What is your suggestion? I mean, how can we solve this issue?
Well, you know, we did a big worldwide study for soft tissue osteosarcoma to try to solve the same problem, and we, you know, got everybody's data from almost every center in the world. And you know, some people use soft tissue sarcoma chemo, some use bone sarcoma chemo. In the end, it didn't look as though chemo made actually any difference in outcome, and it was, you know, more related to local control and surgery and radiation. You know, so maybe that helped a little, but clearly these people need chemo. I mean, they certainly have high metastatic rates, so it's a little bit different, but probably it won't be solved until there's some really underlying molecular mechanism found that actually dictates which truly is better for patients.
Well, Veronika, thank you very much. Let's move on to the 4th presentation. Please, Jay, it's yours.
So yeah, Bruno asked me to present a case, so it's probably a very good multidisciplinary problem. So this was actually a case that one of the radiology fellows put together, Angela Tinga and Carlos Ojila, who's one of the pathologists. And this was just presented at skeletal radiology meetings, so it's kind of a multidisciplinary problem. So it's a 66-year-old man. He came to my clinic with a 2-month history of a painful growing mass deep in the upper thigh involving his quadriceps. It was a solitary lesion on systemic staging. So here's the MRI. You can see it's an intermuscular tumor, dark on T1. It's bright and heterogeneous on T2 imaging. There's lack of GAD enhancement centrally, so there's probably some necrosis. You can see that it's extending right to the femoral vessels. Although it's intermuscular, you can see on the T2 and the GAD scan, it's actually involving most of the quadriceps. It's really, we can't really identify the femoral nerve exactly on this T1 image. And here's the sagittal scans, again, just showing there's high vascularity within it. You can see all these vessels and just the very extensive nature of this tumor. And here's the inflammatory zone around this with a lot of big vessels as well. So the patient had an ultrasound. It was hypoechoic. It was hypervascular, as we can see here, and he had a ultrasound-guided biopsy. So the diagnosis from the needle biopsy was giant cell tumor of tendon sheath, or what we would often in the past call PVNS. So the question, I guess, at this point is, what would you do? PVNS, not often very aggressive. So would you watch and wait, repeat a biopsy, do an open biopsy, go ahead and resect it, as is often done with symptomatic PVNS? Now there's chemo for symptomatic PVNS. You can offer them chemo. So I guess those are the questions.
So we have 50% for repeat and US guided biopsy, 30% for perform an open biopsy, and 10% for watch and wait, and for resect the lesion based on TGCT PVNS diagnosis, and nothing for chemotherapy treatment.
Okay. So the pathologist, the pathology was really very discordant from the MRI, and as a result, we knew that we needed a lot of tissue for the pathologist. We did an open biopsy, and here we can see the low power, and here's the high power. So this was called a histiocytic neoplasm, whatever that means. I mean, we all have these cases, I think, come up on our tumor board, histiocytic tumors, and they're typically sent to sarcoma tumor board as a histiocytic sarcoma, whatever that is, and there's always a discrepancy. Should it be treated by us or should it be treated by the hematologist? There were no mitoses, pinpoint nucleoli. Here are some CD68 and CD56. So there were some immune markers. MIB1 was only less than 1% of proliferation, but it showed a ELK positivity on immunohistochemistry. And this is just a summary of all of the immunohistochemistry slides. So really hadn't gotten too far, although the ELK positivity was interesting. And then I went for molecular testing and came back with an ELK gene rearrangement. And so based on the ELK gene rearrangement, we just called this an ELK positive neoplasm or malignancy. It was the same gene rearrangements that's seen in small cell lung cancer. And so the patient was started on Crizotinib, the same tyrosine kinase inhibitor used for small cell lung cancer. So here's so here we are at presentation, and here we are 6 months later, and you can see there's been a dramatic shrinkage of this tumor. It's much smaller, it's much better defined, although it's still up to and adjacent to the vessels. We still can't see the femoral nerve. It's still involving much of the musculature, although a little bit less so. And the next question was supposed to be what to do next, but you can see that we proceeded with radiation. The reason for that is that we were going to resect this, and we thought we should apply the principles that we do with soft tissue sarcomas. So if we have a large tumor, a tumor where we anticipate the margins to be close, or a tumor where we're going to have to do a very close dissection along neurovascular bundle, where the margins may be microscopically positive, as is the case here. We felt that if for all those criteria, we were worried about the risk of recurrence afterwards, and so we treated this patient with preoperative radiotherapy. And again, the margins look a little bit better defined after radiation, but you can still, even though it's not as extensive a tumor as it was initially, it's still involving all of the same musculature as at the beginning. So after chemo and radiotherapy, the plan was to salvage the femoral vessels, which we did by performing a very close adventitial dissection. When we went to do the surgery, the tumor was still involving all of the muscles. There was extensive scar tissue around the tumor extending into the muscles much further than was visible on the MRI. All of the motor branches of the femoral nerve were encased in tumor, but we were able to mobilize the vessels. So he basically ended up with resection of almost his entire quadriceps and his femoral nerve, saving the vessels. And despite his preoperative radiotherapy and a large resection, the wound healed well. He had very good response to chemotherapy, which is consistent with what the MRI response was. And he's now 2.5 years out. He's disease-free, no local or systemic recurrence. He has to walk with a brace because he has no quadriceps. So he either uses a cane or he uses a brace when he walks. So this is an example of a neoplasm that had very aggressive radiologic features, clearly non-aggressive pathologic features, but we required the pathology help and sequencing to identify an ALK rearrangement. And as we know, a lot of tumors have rearrangements and mutations, but some of the drugs are histotype specific. So, frequently you can have an ALK mutation and not in lung, and it may not necessarily respond to an ALK inhibitor. In this case, there was a very, very good response to Crizotinib. And then the other question, would chemotherapy have been enough treatment for him? But since he had to have this resected, we really, and he had a very locally extensive tumor, we planned from the beginning to use multimodal therapy, so chemo, radiation, surgery, basically everything we could so that we could resect this tumor with a negative margin. And so though we had close margin resection to save the vessels, he did have a negative margin and remains disease-free. So I think that's the message from that case.
Jay, thanks so much. Great case. Awesome. I think there are a few points to address, maybe both from the medical treatment, but also from the pathology, diagnostic. Who wants to start?
Just a question, Jay. What is the definitive diagnosis for this patient in your center?
In the end, it was just called an ALK positive rearranged malignancy. That's it. So initially, it was called descriptively. It was called a histiocytic tumor, but ultimately, it was just called a histiocytic tumor with an ALK rearrangement. So there was no definitive sarcoma diagnosis, but it sort of presented like, responded like, ended up being treated like sarcoma.
But do you know what partner was it? What gene fusion it was, or just you said about sequencing? So you did.
Yeah, so I don't have it. They said it was the same. It was the same rearrangement as non-small cell lung.
Jay, there is another entity where there is an ALK alteration. Is angiomatoid histiocytoma.
Yes, I know that.
We have 3 or 4 cases like that, inflammatory process like a PVNS, and we make an ALK test, finding some gene alteration. It's not maybe a fusion gene, but it is overexpressed. And I have 3 or 4 cases like you demonstrated in front line a decrease of tumor mass. So it could be this family ALK. We have to define this kind of new entity, maybe by
there is an entity of epithelioid inflammatory myofibroblastic tumor, and I think that would rather fit in this category. I probably would call something like that in I don't know, SMA, but this is just name giving kind of. It's probably this change, like NTRK rearranged tumors, which is now kind of official WHO entity, so maybe we kind of heading this direction as well.
I think that this case very well shows that if we do not really know or can give the tumor a name, that we should go further for molecular analysis. And I think in future we will learn much more by doing these sequencing procedures. And if you look at all the papers Christina Antonescu is publishing, we have this kinase fusion tumors, which are not only tumors with NTRK fusions, but also others with ALK fusions, RET fusions, ROS fusions. And I think over the years, by doing these molecular tests, we will learn much more about the morphology and about the overlapping features. And even if you have a biopsy, such a large biopsy from a part of the tumor, it may not represent another part of the tumor where you have the necrosis and maybe more mitotic activity and more atypia.
But nevertheless, I think we could call it an inflammatory myofibroblastic tumor. So
yeah. So if we want to put it one of the existing categories, we probably this direction up till now, but we'll definitely will kind of move the direction, changing the nomenclature in the future as more data are collected.
And the other key message of this case is when there is a discrepancy between the first diagnosis and radiology, don't hesitate to make a new biopsy with more material and to make biological tests.
Awesome. Joanna.
When it comes to the oncological treatment, you of course go for this kind of an agnostic marker, the ALK rearrangement. So at the end of the day, that's the target for our treatment. And the histology doesn't matter that much for our treatment.
Philipp?
I would like to come back to Axel's very important point of doing a rebiopsy. And that is, Jay, I think pretty much that in all our centers, ultrasound-guided biopsy probably is the gold standard for soft tissue expansions. What is your standard procedure upon inconclusive diagnosis after ultrasound guide? Is it dependent on the individual patient where the tumor is situated, or do you have like a standard procedure where you say, no, we never do another ultrasound-guided biopsy, but we do open biopsy? What do you recommend?
Well, it's interesting because when all these cases obviously come to tumor board, and when one of the problems I think all of us have is resource issues and doing biopsies in the OR, and frequently when we're at tumor board and the biopsy is inconclusive or necrotic, and they say we need more tissue, the first thing is, well, can we just get another ultrasound biopsy? And then usually they'll say we did the best biopsy we could. So if we repeat biopsy, what do you think? Why is it going to be any different? We targeted the solid area. So often they say, sometimes they will, like sometimes if there's another area that's solid, they'll target it. But if it's really highly necrotic and there's not a good targetable area, for them to likely be able to get solid tissue, then we'll just do an open biopsy to not waste a lot of time, right? Because, if you go through a biopsy and then you wait for regular pathology and then you do molecular and then a month has gone by, and if you don't have an answer again, and then you have to do an open, it takes a long time if people have a growing mass. So sometimes it depends on the rapidity of the patient's symptoms and their growth. Sometimes it depends on what the, likelihood, like if we get a biopsy from an outside center that's inconclusive, we would always just repeat our own ultrasound biopsy in our center. They're probably much better. But if they've already done it in our center, it depends a bit on what the MRI shows and what the rapidity of the patient's symptoms are in terms of, and how quickly we can actually even do an open biopsy. But I think sometimes just getting a lot of tissue gives a pathologist ample opportunity to redo everything.
Any further comments? Well, Jay, I thank you also very much. I think with all these great cases, we had really an intense discussion, and shows that there is a lot to discuss, a lot to exchange, and obviously a lot to learn. And I'm very happy about this, that we have this opportunity, despite the fact that we had now a little bit longer than foreseen. But I think it's really a very nice addition. I would like to thank everyone who prepared these great cases. There's always a lot of time and effort, and it's really nice that you share your knowledge with us. And for all those who are here and also those who were listening, having said this, for the future, please feel free I mean, you can present cases, we can discuss them like we did it today. And I think we would like to further foster this exchange also on an international basis. I think that would be great. So we have a name for next year. What remains is wish you all the best for the last few weeks of this year, and looking forward to see you on our next webinar in the beginning of January. And all the best. Have a great evening. Bye.